Good morning. I'm Geffen. I'm the head of the Division of General Internal Medicine, and it's my pleasure and honor to introduce our speaker this morning for Grand Rounds. This is part of the annual Pecoraro Lectureship in the Division of General Internal Medicine, which is our main annual invited lecturer. This is in its 27th year, and as I said, it's an honor and a pleasure to be able to introduce Dr. Clarence Braddock, who's this year's lecturer. Dr. Braddock is currently the professor and vice dean for education and chief education officer at the David Geffen School of Medicine at UCLA. He has a very distinguished academic pedigree, which includes a stop at UW. But before that, he was an undergrad at Stanford, attended medical school at the University of Chicago, then enlisted in the Navy and did his residency at the Naval Hospital in Oakland, and served in the Navy as a medical officer at Oakland, aboard the USS Wichita, and for 3 years in Naples, tough duty, and was in those places, had various titles, including Chief of the Medical Service, Chief of General Internal Medicine, Director of ICU, and head of the HIV programs. He then went to the San Francisco VA, where he was also acting chief of the Division of General Internal Medicine and director of the ICU. And it was about that time that I met Clarence, and we were fortunate enough to persuade Clarence to abandon his job in San Francisco and enter a Health Services Research and Development Fellowship here in Seattle. And Clarence then, following his fellowship, remained at the VA, where he was the Associate Chief of Staff for Education, and then was lured over here to the university, where he was the Associate Chair in the Department of Medicine and an Associate Professor in Medicine and the Department of Bioethics, Medical History, and Health Services. Unfortunately then, shortly thereafter, Dr. Braddock was lured back to Stanford, where he was on the faculty and directed a newly established Center for Medical Education Research and Innovation, and was the Director of Clinical Ethics. About 5 years ago, I should say he rose to the rank of professor at Stanford, and then about 5 years ago was recruited to his current position at UCLA, where, as I said, he is the Vice Dean for Education and Chief Educational Officer. He's been very active in a number of professional societies. He's been a member of the Board of Directors of the American Society for Bioethics and Humanities. He's been on the Council of the Society of General Internal Medicine, and he's been chair of the Board of Directors at ABIM, and is on the Board of Trustees for the ABIM Foundation. He's received several honors along the way, including a Naval Commendation Medal. He's been well funded by numerous research grants, federal and foundation. He's published more than 70 peer-reviewed articles in prestigious journals, written 12 book chapters, and has developed a national reputation as a leader in medical education and medical ethics. And it's my honor to welcome him for his lectureship here, and the title of his talk is 5 Big Ideas in Education, in the Education of Physicians. So thank you, Dr. Braddock.
Thank you. Thanks, Steve. Appreciate it. Well, good morning, everyone. Thanks, Steve, for that wonderful introduction. It's quite special to be back here. It's interesting, even after you've been gone for 15 years, certain things just the familiarity has just been wonderful. The opportunity to reunite, reconnect with folks that I had the opportunity to work with, that I consider colleagues and friends, and so it's been a very wonderful experience, and an honor to be the Pecoraro lecturer. So today, the 5 big ideas, my goal here is to have us have a conversation about ideas in medical education that are really guiding change, maybe guiding change here, certainly are guiding change around the country, and have become important as we at UCLA are looking at revising our medical student program. For those of you in the audience who are education geeks like me, there'll be a little bit of kind of highfalutin terminology, but I'm also going to try to provide some practical examples of ways in which we can fundamentally start to rethink the way that we train future physicians. Specifically, there will be sort of 5 paradigms of thinking that are really certainly influencing my own thinking about medical education. I think are influencing many people around the country, if not the world, and to explore together what the implications of this is for the training of physicians. And these ideas are relevant both to medical student education, to training of residents and fellows, and to continuing medical education and lifelong learning. So there are 5 ideas. Talk about the idea of medical education as a continuum, workplace learning, mastery learning, entrustable professional activities, and self-regulated learning. First, let's start with medical education as a continuum. So I'm going to talk about 3 ideas in this first category. One is the recognition, which is obvious to many, that medical school is primarily preparation for residency. Now, that might seem to be dismissive of medical school, but it's just the reality. 150 years ago, medical school might have been, the MD might be considered a so-called terminal degree, not in the sense that we think about terminal, but in the sense of with an MD degree, someone could go into practice. That's no longer the case. It's no longer the case. Second, we recognize increasingly the lack of alignment between the goals of medical school and the needs of residency with regard to preparation for residency and residency outcomes. And on the heels of match season, those of you involved in residency recruitment, I'm sure can reflect on that. We'll talk more about that in detail. And finally, continued growing concerns about the length of training. So first, this shows 2 individuals who actually look like they're related, but they're not. Anyone know who the person on the left is? Flexner. Person on the right? Dave Irby. Used to work here. So these individuals are separated by about 100 years. Abraham Flexner, as you know, was asked by the Carnegie Foundation circa 1910 to visit every medical school in the United States. He did, literally, got in his, I was going to say car, probably wasn't a car. It was a train or, buggy, and went to every medical school in the country. There was hundreds of them at the time. And the report that he published actually transformed medical education to the model we have now, more or less. A strong basic science foundation followed by apprenticeship in areas within a teaching hospital. Yes, that was launched in 1910. Irby and colleagues were asked by the Carnegie Foundation 100 years later to write a follow-up report. They didn't visit every medical school in the country, but they visited a lot, and they've transformed our thinking, and many of the ideas I'll talk about today are in this book. So if you're a medical education aficionado, you've probably already read it, but it's actually a fascinating read about ideas that pertain both to medical student education and residency education. So one of the ideas is this notion of a continuum. This is actually an adaptation of the so-called Dreyfus model of growth of expertise. You see from novice, advanced beginner, competent, etc. Superimposed on the transition from undergraduate medical education, i.e. medical school, to residency and to practice. And this idea has, I think, really captures this notion of education as a continuum. Probably no particular observation, though, captures the importance of education as a continuum more than this notion of the alignment between medical school and residency outcomes and the advent of the boot camp. This is a paper about a simulation-based mastery boot camp that appeared in academic medicine a few years ago. But my main point is that if you ask yourself, why do residency programs have boot camps? Residency programs have boot camps because they recognize that trainees coming in the door on the first day of internship are varied in their preparation for that first day, for that first call, for that first patient. If that sounds a little strange saying it that way, it should sound strange. Why do medical schools produce candidates who on the first day of training are not prepared for the first day of training? This lack of alignment has spawned the growth of boot camps. Now many medical schools are running capstone courses, which are the medical school equivalent, which are basically sort of, acknowledging the fact that for whatever you've been doing for 4 years, it hasn't actually gotten people ready for the first day of residency. So there are some pilots that are popping up, and actually some medical schools are doing this in a more formal fashion, the idea of actually thinking about maybe we shouldn't have medical school and residency separate. Maybe there should be kind of one continuum. So this is a paper on a pilot of a number of pediatric programs around the country who did just that. The model looks something like this. A medical student starts in their first year, just like every other medical student. They have an interest in pediatrics, which after the end of their first year, they kind of do some service learning activities in a pediatric kind of environment. And as a second year student, they're still doing the same curriculum, but they begin to sort of differentiate their programs, particularly their longitudinal clinical experience, to focus in pediatrics. There's an opt-out at the end of the second year, but students who continue to demonstrate an interest in pediatrics go into the third year, where they're doing the same rotations, but again with a pediatric flavor. When they do surgery, they do pediatric surgery. They do outpatient continuity, they're in a pediatric setting. And finally, in the fourth year is kind of a hybrid. Once they've met all the competencies, they actually seamlessly transition into a PGY1 in pediatrics. Lots of advantages. Repurposes the fourth year, come to that later. They don't have to worry as much about step one, they just have to pass it. That's pretty profound. And importantly, it does shorten training. So these models have proven to be rather interesting, and the early returns suggest that these trainees do just as well as trainees in a traditional area, and you eliminate that sort of need for this sort of awkward transition between medical school and residency. So the growing concerns about length of training. So when I was at Stanford one day, the phone rings, and it's the office of Victor Fuchs, Nobel economist. So when Victor Fuchs calls your office and says he'd like to meet for lunch, you ask, what day would you like to meet for lunch, Professor Fuchs? I had no idea what he wanted to talk to me about, but I decided to go to the Stanford Faculty Club and have lunch with Victor Fuchs. So we were having a nice lunch, exchanging pleasantries. He's asked me about what I do. And finally, he cuts the punchline and says, why is medical school so long? And so Victor Fuchs says, well, in engineering, you start off as an undergrad, you do 2 years, everybody does the same thing. Before, the rising juniors are all asked, what kind of engineer do you want to be? Mechanical, civil engineering, electrical, and they begin to differentiate. Why don't you do that in medical school? Well, I didn't have a good answer for him, and in fact, he went on to continue to talk to lots of folks, including Zeke Emanuel, and they wrote this paper basically proposing that medical school should be shortened by at least 30%. Well, that idea has actually been percolating for some time and has led to the growth of a number of different shortened pathways. This diagram, I'll just walk you through it, shows they all have a common feature, the notion that the first 3 years of medical school are largely the same, but the fourth year might be an early exit or early entry, depending how you want to look at it, into something else. There are models that are very focused on primary care and accelerating entry into primary care fields. UC Davis has a program they're now doing in collaboration with Kaiser Permanente. There are some that are short-tracking individuals into research, and these have the following, again, features. It's a faster trajectory, again, into residency or into a career as a physician scientist. It's repurposing the fourth year, and that's been a long lament for particularly medical student educators, is like, what's the deal with the fourth year? And it's also importantly reducing debt burden. So this is something you're seeing around the country, the idea of either a combination of a medical school residency continuum or at least the option for an optional sort of third year, a three-year program. So this idea of medical education as a continuum has really taken root, and you can see all the various ways in which it's manifest. The second big idea is workplace learning. So workplace learning, there are a couple of ideas that are really a part of that. For those who are deep in this area, I apologize, there'll be a great oversimplification, but they're a couple of important ideas. First is the notion of a community of practice. So this diagram is a schematic to show the various ways in which a clinician or a trainee might interact in a particular clinical environment. It might be a clinic, it might be an inpatient ward, but in either case, think of this. The core group are the people who work there every day. The nurses, the MAs, the staff who live and work there. They don't live there, but they work there every day. Their full membership is afforded to those who don't work there every day, but work there on a regular basis. So if you're attending in clinic, maybe on Monday morning it's endocrine clinic, and on Wednesday afternoon it's pulmonary clinic, but when the endocrine faculty and house staff come there, they're full members. When Wednesday afternoon comes around, it's a pulmonary membership, but they're full members of that community of practice. There's peripheral participation. I'll come back to that in a moment. Transactional participation means individuals who come into that environment have a specific task. On an inpatient unit, it might be the consultant coming in or the respiratory therapist. They come in for a particular task or set of tasks, and they leave. But those individuals are afforded full recognition as members of that community of practice. Peripheral participation means individuals who have a role. It may be more peripheral, but they're afforded some degree of citizenship, if you will, in that community, as opposed to those in the passive access. Passive access are travelers who are passing through, observing, taking note. They may be doing a lot of observation, but they don't actually have a job. They're not actually directly taking and doing any of the tasks that community of practice is dedicated to. So if you think about for a minute the typical experience of a medical student, first or second year medical student doing a preceptorship, a third year student doing their clerkship, a sub-I, where would you put those individual medical student experiences on this schematic? Where would you put a medical student doing a preceptorship, coming in to practice their H&P? You might say transactional, but really the H&P that medical student is doing is of no value. I mean, not to be pejorative, it's of no value to the patient. It's of no, they might like the idea that they're contributing to the training of a future physician, but it's not adding value to their care. It's not even adding value for that community of practice. The third year student, maybe a little bit better. They're with a team, they're rounding every day. But fundamentally, maybe in the old days, but now there's so much emphasis that medical students in many settings can't even write a note in the medical record. They are in the passive access, I would argue. Sub-Is, it might be trending a little bit more, but my main point is that if you want to be acculturated and really have your professional identity develop, you need to be part of the community of practice, and that's just not happening. The second concept that's important for workplace learning is signature pedagogy. And this is something that I learned from Lee Shulman, who was a longtime president of the Carnegie Foundation. Signature pedagogy is a type of learning, the fundamental approach in the education of practitioners that is a signature of that profession. Signature of that profession. Many will remember the classic movie Paper Chase. It's about the training of lawyers. And there's a certain thing, if you say training of lawyers, certain vision pops into your head of maybe it's in the classroom, someone calling out a student by name and saying, in the case of so-and-so v. so-and-so, what did Justice so-and-so? I mean, there's a certain model that pops into your head. As you think about the training of physicians, what would you say is a signature pedagogy in medicine? Just call it out if you think of it. Pimping on rounds. I don't personally like the term pimping for reasons that, I think many would agree with, but I think what the point is, the idea of Socratic questioning on rounds of a clinician, a patient, and a learner. That is the signature pedagogy in medicine. And I tell you, every time I've given this talk or versions of it, everyone gives the same exact answer. And then I ask you, when does that actual form of teaching begin in medical school? It begins rather late. And so the idea is that when students are first and second year students, they're asked questions, but it's like, okay, class, what are the 3 causes of hyponatremia? Anybody? Anybody? That's not pimping, right? There's not that accountability. So that's kind of brought forth the idea that what we really should be thinking about is how do we make those kind of signature experiences for medical students happen much earlier. And it has to do with the need to create early and authentic experiences. And there are lots of them that have popped up. Many undergraduates are functioning as scribes in a variety of environments, emergency departments, busy subspecialty clinics, health coaches. A number of medical schools have their students trained as health coaches, but they actually have real work. The key thing about authentic experiences is that it's real work. It's actually contributing value to the patient. Yes, there's also learning, but it's contributing value. Being on quality improvement teams, student-run free clinics are a great example of an authentic experience. And it's interesting to think about them as obviously it's primarily out of the desire to provide service, but it's also a fabulous and rich educational experience. Even research assistants, being on hospice and palliative care teams, making home visits. There are a lot of ideas that have popped up where you can have first and second year students having actual clinical roles. They're not being, like miniature doctors, but they are contributing to the care of patients in meaningful ways. One example, this is from Hofstra, one of the newer medical schools. They're incoming medical students. The first thing they do is they get trained as EMTs. They get trained as EMTs. They actually go on and they do the whole training program. And the goal is to kind of begin to give them a tangible skill set. So when they do land in a clinic or another environment, they actually can do something. The second is to begin to think and have them have actual authentic interactions with patients where they have some skin in the game, they have a responsibility, and that it really starts to shape their professional identity. This is another example of Elder Navigator program. Again, these are individuals who are actually assigned to older patients that literally help them navigate the healthcare system from appointments to lab to follow up with them between visits. Again, a very authentic experience that first and second year medical students can do. And this is a school in Florida, FIU, again, another relatively new medical school. They created these teams of students, medical students, social work, and nursing, who are assigned to do home visits, home safety evaluations, medication stuff. And again, these are legitimately authentic roles that first and second year medical students can do. So if you want to create these early authentic experiences, what I get asked all the time is how do we create time for these? And it's not an easy question to answer, but some places have sort of looked at curricular compression, using different modalities to create more time and blank space in the program, such as flipped classroom or online learning. Probably the best example of curricular compression is Duke Medical School. Any Duke Medical School alumni here? No one from Duke? Well, Duke in probably late 90s, I want to say, actually completely transformed their curriculum to put 2 years of medical school into 1 year. The second year of medical school is like the traditional third year, the rotations you see, medicine, surgery, peds. The third year is completely free. Duke decided to create that space primarily for scholarly work because they believed they wanted to create future physician scholars. And then the fourth year is the more traditional. This is an example of curricular compression, and it's a trend. Many medical schools have gone from 2 years of basic science to 18 months. I believe you recently had curricular compression here. So it's one strategy. The flipped classroom, basically the idea is that the content delivery is done outside the classroom, and you reserve the classroom time for application. So one example of that, this is a space that was created, actually the prototype was originally created at MIT. They call it TEAL, Technology Enabled Active Learning. And it was a space where you could do team-based learning, where teams of individuals were working on applying, in this case, engineering concepts with one faculty member, and the screens around the room enabled them to see images, to put up the products of their work. And it's just another way to kind of think about how you create a space in the learning environment to actually allow you to do a different way of teaching. Online learning has started to creep its way into medicine. Probably the best example of that is a program created by Harvard as part of their new curriculum called HMX. HMX, what they've done is they've created, to date, 5 online courses for medical school. Physiology, biochemistry, pharm, immunology, and genetics. And each of those has the following features. There are short, highly produced videos with animation, high-quality animation. There are embedded assessments. There's online asynchronous sort of discussion groups. It's actually a quite sophisticated platform. If you're thinking about, gosh, we should get that, I'll warn you, it's very expensive. It's Harvard. But it's actually quite remarkable. And this idea is one of the many ways in which people are trying to create more space and time for other activities, including early authentic experiences. So workplace learning, as you can see, has also been a very transformative idea. The third is mastery learning. Mastery learning is a very complex field, but I'll distill it down to really sort of two ideas. Traditionally, we've sort of had a time-based approach to training future physicians. A fixed amount of time, but recognizing that leads to variable performance. You take a 4-week clerkship, you do a 1-month rotation in cardiology, you do all these things are time-based experiences. The idea that the same amount of time could lead to the same level of mastery, of course, doesn't make sense and has been replaced by this notion of what we should be doing is being clear about the outcomes and letting time be flexible until the learner achieves those outcomes. Let me show you a diagram. In this diagram, the little orange circle here shows a sort of typical kind of course. You teach, you give an exam, there's a bell-shaped curve of how people do on the exam. This line represents the passing threshold. That's what happens in a typical course. Some people pass, some people don't, time-based. Mastery learning says that your goal is you have a fixed outcome, it's here, and individuals continue to go through that learning experience until they demonstrate mastery. The ultimate of that would be if you couple that with individual tutoring, you actually can have an educational program where literally everyone who completes that program does master the material. One example that always comes to mind is ACLS. It's been a while since I've taken ACLS, but I always remember the mega code. Do they still do the mega code? They still do the mega code. I'm glad to know that. So the mega code is a mastery experience. You do not finish ACLS until you have gone through the mega code and demonstrated that you are able to do the core features. Same thing with BLS. You do not graduate and get your BLS certificate until you successfully demonstrate that you can do CPR. That is mastery learning. So it's not a new concept, it just hasn't been part of our lexicon. So this notion of being able to have people that start at different points, some people will get to the outcome very quickly, some will take longer. Now the biggest barrier here has been that if you say this to a program director, their head explodes. Because the notion of having trainees who might be here for 2.5 years or 3 3/4 years, it's just not a pretty sight, but it's actually a fascinating concept. The essential features are you have to have a good baseline assessment to figure out where learners are. It's important to have learning objectives and activities that are specifically designed to meet those objectives. It has to be really done in a disciplined way. You set some minimum performance threshold, what you think mastery equates to. You have iterative performance assessment to let learners know how they're doing, how they are approaching mastery, giving them feedback, frequent feedback. And advancement is contingent on achieving the minimum threshold. A 4-week clerkship in internal medicine might be 2.5 weeks, it might be 6 weeks, it might be 9 weeks, depending on how long it takes that learner to achieve the minimum threshold. And that study and practice continues until that threshold is achieved. One example that's kind of come out of this is the notion of progress testing. So again, in medical school or sometimes in residency with in-training exams, people are taking exams at different intervals, but progress testing takes this notion of mastery learning and iterative assessment to a very specific place. So in progress testing, this is a diagram that shows in medical school, imagine if you gave the equivalent of step 1 to students every few weeks from the beginning of medical school until the end of the 2nd year. I know it kind of gives you like a little pit in your stomach. Oh, that sounds so painful. But the idea is that what you're doing is you're saying, here's the mastery threshold, and we're going to be able to have you sort of see how you're progressing towards that mastery threshold and what your gaps are. So in progress testing, the individual sees what that graph shows is the little green line is the individual. The red is subpar performance. Blue is acceptable performance. Here's the average performance, and this is the aspirational level. So that individual you can track to see when they've actually mastered. And on the right-hand side, you see by sort of discipline. And you see this individual is in the range for preventive health, not quite there for stages of life or science and methodology. So providing that feedback to the learner actually gives them a way of targeting their continued practice and improvement to achieve mastery. So this is an idea that's going around a bit as well. It's also kind of emphasized the need for deliberate practice as a paradigm for the actual teaching method. Deliberate practice is a methodology that has been popularized largely by this thing that's attributed to Malcolm Gladwell. He actually didn't, he wrote it in his book, but he actually didn't come up with it. It was the work of Anders Ericsson, and this is the idea of 10,000 hours of practice. So Ericsson, a cognitive psychologist, studied concert violinists, chess masters, and what he determined is that was a common thread in mastery, true mastery to a very high level, was not just practice, but a very particular kind of practice. Repetitive practice in different situations with immediate feedback that actually is developing expertise, and a form of expertise called adaptive expertise. So that's where the 10,000 hours comes from, but you realize again that that 10,000 hours of practice to achieve mastery also might make your head maybe not explode, but it starts to get near to explosion. But there are people who have actually adapted this into medical training. This is an example from the University of Toronto where they're looking at a pediatric cardiac surgery program, and they use this notion of deliberate practice and mastery learning to create the following experience. So the trainees start with a knot tying simulation and suturing anastomoses with Penrose drainage, and they don't move on until they've demonstrated the ability to create a watertight anastomosis. They're just doing that for however long it takes to do that. They move forward, and eventually they get to a simulated beating heart model, and they keep doing that until they can demonstrate the suturing, they can demonstrate all the steps, including the shunt procedures and everything accompanied with it. So this is mastery learning and deliberate practice. As you can imagine, it's challenging to our typical paradigm, particularly around scheduling, but it's been a very transformative idea. I mentioned adaptive expertise. We typically think of expertise as being linear, and another kind of important offshoot of deliberate practice is the idea of adaptive expertise, the idea that one isn't just trying to move through experience from novice to having clinical expertise in routine areas, but importantly, the adaptive expert has the ability to apply knowledge and experience in new situations. The best example of that is probably pilot training. So when pilots are training and are in the flight simulator, they're learning to land the 777 in normal weather conditions, and with a crosswind, with one engine out, without landing gear. They put them through all different kinds of situations, not so they can master each one, although they do, but importantly so they develop the ability to master a new situation, a novel situation when it arises. And in medicine, that's obviously quite critical. So mastery learning is the third idea. The fourth is entrustable professional activities. I imagine lots of folks have heard of EPAs. You've heard of EPAs? A few? Okay, good. In a nutshell, this was an idea that came on the really as an alternative to competencies. Competencies, long list of things that people are sought to achieve. EPAs kind of tries to roll those up into discrete activities that make sense as an integrated unit, and can form the basis of workplace assessment. It's also based on this idea of entrustment, and I'll give you an example. So this is an implementation of EPAs in a medicine residency program published from a few years ago. What they did is they first mapped out what they called observable practice activities. Don't ask me why they didn't just say EPAs. They wanted to have their own term. And they broke those down into process EPAs, like performing an accurate history and physical, and to specific EPAs. The first one there says, choose the appropriate antibiotic for neutropenic fever. And what they asked is they did regular assessments, and they asked the assessors not to say, did they place the order in Epic, they didn't break it down by specific steps. They asked the following question about, can you trust the trainee to perform that task, choosing the right antibiotic for neutropenic fever without supervision? Level one was, I don't even trust them with supervision. I hope we don't have anyone like that here. Trusting with direct supervision, trusting with indirect supervision, meaning somebody's available within a reasonable proximity to help, trusted independently, and an aspirational level where they're trusted independently and they might even be trusted to supervise others. And then they track the residents across with multiple assessment points, and this shows 3 hypothetical residents. So this little line here with the little diamonds, that's the average. So this trainee is entrusted at a level above what's expected for that level of training, or at least what's the average. This person here is having a little bit of trouble. It's getting close, but not quite there. And this person is more variable. But the idea of entrustment is that It changes from competencies, which people find really hard to kind of conceptualize, to the entrustment decision, which many assessors find much more kind of intuitively obvious. If you ask someone, do you trust the trainee, you literally got to, when you get ready to leave at the end of the day, you know what that is. Like, should I leave or should I run back to the ward or the clinic? It has a certain meaning to folks. It's much more relevant. That has led back to this notion of the continuum to the following really interesting idea. Is, could the EPA be used as a tool to better align medical school outcomes with entry residency requirements? So this led to a group a few years ago coming up with this document, which is called the Core and Trustable Professional Activities for Entering Residency. Translated to common vernacular, you ask residency directors, what do we want to be absolutely sure people know or are able to do on day one? I don't want to have to do boot camps anymore, and turn those into outcomes for medical school. So they came up with this list of things. They described the activity, tried to map it on the domains of competence and subcompetence, and translate it into behaviors, and then contrasted the pre-entrustable learner and the entrustable learner. Let me give you an example. So on the left-hand side are pre-entrustment versions of the EPA Gather a History and Physical. So this is based on the idea, again, if you're a residency director and someone asks you that question, what do you want to be sure? You don't want to have to worry about doing a boot camp around doing an accurate H&P. When your R1 starts on day one, what's the day on for you, June 20th or something? June 25th? Oh, you guys are easy on them. June 25th. June 25th, the first day, the first patient, you don't have to worry that they don't know how to do an H&P. So the medical school should say to you, we guarantee, we can say this person is ready. But on the right-hand side is what entrustment looks like. So a person incorrectly performs physical exam maneuvers should not graduate from medical school. They should not graduate from medical school if they can't, assess jugular venous pressure, or if they can't tell, whether or not a patient has a murmur, or they can't tell if they can't do it. Those are things that they should not leave medical school until they can do. That would be mastery learning translated into EPAs. So this idea, very, very important advance. There's been debate about whether they've chosen the right EPAs, and that wasn't probably enough dialogue, in my view, between the GME world and the medical school world. But I think it's a very interesting idea. And fundamentally, if we wanted to address the continuum gap, I think this is a promising approach. This is an attempt by one author to try to align the competencies with EPAs, and it's a work in progress. And again, I'd invite you to follow that along in the literature. The last idea is what I call self-regulated learning. And self-regulated learning is a relatively new idea as well. And I think it's important in part because of the impact it has on the learner. So this will be really education geeky, but self-regulated learning is largely about metacognitive processes that the learner uses to plan, monitor, and evaluate their own learning. And the use of approaches that use self-regulated learning are largely to try to help the learner to become more aware of and practice in regulating their own learning. Metacognition, in short, is thinking about thinking. It's literally saying, how do I think about this problem, not what do I think about this problem. And having the learner develop some insight into how they learn or how they can learn can be enormously helpful. There's emerging research that shows that a self-regulated learner can improve their academic performance. Importantly, it kind of becomes a platform for lifelong learning. And what's really, I think, interesting and emerging evidence that the self-regulated learner, by creating a sense of empowerment and agency in their own learning, has a more career fulfillment, and it actually contributes positively to well-being. As we think about all the attention and concern we have about burnout and resiliency, this is an important thing to keep in mind. So this diagram shows the process, and this is from, if you want to learn more about it, this is a great little summary of self-regulated learning. The idea is that there's a early phase where one is trying to understand and plan their activity, the performance phase, and in the self-reflection phase, what's really critical is how the individual reflects on learning and reflects on the gaps in learning. We've all heard about reflective practice and the idea of reflection. That's really become quite common in the vernacular of education. But this is asking us to go deeper, not just think about what we did, what we could do better next time, but to think about what were we thinking, how were we thinking about that problem. I'll give you an example. So self-regulated learning has been used to create a new approach to remediating, in this case, medical students who have difficulty with multiple choice exams. It could be applied the same way to clinical reasoning. These are two areas that are really thorny when you think about remediation. Someone is a poor test taker. What's our typical recommendation to a poor test taker? Take more practice tests. When you think about it, if you're a poor test taker, how is taking more practice tests going to make you better? And in fact, the research shows it largely doesn't. So what could we say to the test taker? So this is an approach, I think from Uniform Services University, that actually tried to use a self-regulated learning approach to break down the task of a multiple choice exam with very specific metacognitive questions and inquiry. And through that, they identified some common pitfalls as individuals who struggle with multiple choice tests. What were the typical sort of problems? They didn't recognize the illness script that was embedded in the STEM. 57-year-old man with chest pain. They didn't have specificity. It's something with the heart. Had premature closure. Must be MI. They forgot about other causes of chest pain in a 57-year-old man. Underconfidence. They find themselves at the multiple choice question. They think it might be A, but it could also be D. They weren't confident in their choices. They had inappropriate attribution of causation, so they tended to put too much emphasis on some aspects of the case and explain away others. Well, the 57-year-old man with chest pain has pulses that are different in each arm. I don't know what that is, and they just threw it away. And the fact, importantly, that at the end of the case, when they get the answer wrong, they just throw up their hands. There's no way to adapt, create adequate inferences from struggle. So what they created was a protocol to actually walk an individual through a multiple choice question, breaking these things down and actually creating opportunity to practice on these different pitfalls. So this is part of their assessment form. And what they would do is they would take the typical multiple choice question. There's like the little vignette. There's the lead in, which is the following is the most likely diagnosis. I know I'll probably give you PTSD right now. And then the 5 choices. And they would cover up everything but the STEM. And they would force the learner to read the STEM and think aloud what they think the person has. In this scenario, to identify particular diagnoses, to call out those things that supported their diagnosis, and to call out those things that are inconsistent. All these steps are mapped onto those common pitfalls and allow the instructor to give specific feedback about what else could it be, and help them to practice those kinds of questions. The question, for example, of premature closure. The antidote is, okay, pause for a second. When you find yourself in that situation, ask yourself the question, could it be something else? And with this approach, they found that, again, it's early study. I think when I heard this presentation, they'd done this with maybe a cohort of 25 or 30 learners, but the early returns were quite positive. But this is an example of self-regulated learning on the remediation side. This is a diagram from a National Academy of Medicine publication on well-being, and I won't attempt to try to talk about the whole field of learner well-being or clinician well-being, but we know it's a very important issue, very front of mind for many of us. But I would point out the following, that most of our approaches to looking to address learner well-being have focused on managing the workload, all the way back to duty hours, to bring in other kinds of support to make sure the workload is manageable. Social support, trying to have mentorship, peer support, all these are good things. Looking at things beyond the work, assuring that we have adequate support services for mental health, for physical well-being. But we haven't done as much of it, and I think where self-regulated learning has a lot of potential is the idea of confidence, agency, and sort of self-efficacy. If I'm a learner who's on the bubble, struggling, if I have an approach where I don't feel lost, adrift, if I can have agency in managing and controlling my own learning, that could have potentially very strong positive influences on my sense of self-efficacy and well-being. And there's a lot of writing, not so much in medical education literature about this, but I think you'll hear over the coming years more emphasis on this idea of ways in which learning can be created to actually give agency to the learner, not just put them in a small group with a bunch of other learners, not just have them continue to practice, do practice tests, but actually use this metacognitive processing to have them realize, oh, I actually can understand how I learn, how I could learn, and I can actually control that to some degree. So these are the 5 big ideas. Again, I hope you find them interesting. I chose them because they're things that are relatively recent that we're beginning to see both kind of conceptual but also practical application of them to the training of physicians. And I think it offers has a lot of implications for the training of physicians, both the things that we do with medical students, with house staff, and even with practicing physicians. So thank you very much for your kind attention. I'd be happy to take some questions.